here is your question. Right, so if you have read and understood, considering it surgical anatomy station, kindly tell me if you can identify the labeled structure, or in other words, can you tell me how many triangles there are in the neck, or how the neck region is divided in two triangles?
To tell about the divisions, there are generally two divisions, anterior and posterior part. Anterior, which is divided by sternocleidomastoid muscle.
Good.
And in anterior division, and there are submandibular triangle, submental triangle, muscular triangle, and carotid triangle.
Yes,
muscular part and carotid triangle.
Can you also please tell me how these triangles are divided? Anterior?
Anterior and posterior are divided by sternocleidomastoid.
Yes.
And for the carotid sheet, for the carotid triangle, it is surrounded by posterior belly of digastrate superiorly, and superior belly of omohyoid inferiorly, and anterior border of sternocleidomastoid posteriorly.
Okay, that makes 4 triangles in the anterior region. And how many triangles in the posterior region, please?
In the posterior region, there are 2 above the omohyoid and 1 below the omohyoid.
Okay. So what are the contents of the posterior triangle?
It contains,
yes.
Yeah, it contains spinal root accessory nerve, brachial plexus, cervical plexus, and a phrenic nerve. And then for the arteries and veins, they are like suprascapular artery, transverse vagal artery, and brachial, subclavian artery, along with their veins.
Okay, can you please also tell me the contents of carotid triangle, please?
The contents, carotid triangle mainly contains carotid sheet, common carotid artery, internal carotid artery, external carotid artery, and vagus nerve between internal and external carotid arteries. And cervical is embedded in the anterior part of the carotid sheet.
Okay.
Along with lymph nodes.
All right, good. All right. Okay. Can you please tell me quickly what is the course of spinal accessory nerve?
Spinal accessory nerves?
Yes.
It runs in the posterior. Pardon me?
Surface anatomy of spinal accessory nerve first, please.
Yeah, it runs in the posterior triangle, starting from the point on the posterior part of sternocleidomastoid between the upper 1/3 and lower 2/3.
Yes.
And it runs down to the trapezius.
Yes.
To the point between upper 2/3 and lower 1/3.
Okay, and this nerve supplies which muscles?
It supplies 2 muscles, sternocleidomastoid and trapezius.
How would you test the functions or action of trapezius? Just to make sure if spinal accessory nerve is functional or intact?
Yes, to test the trapezius, ask the patient to shrug the shoulder. For the sternocleidomastoid, ask the patient to turn around to the other side.
Good, shrug the shoulder. Okay, Can you please identify structure C over here? What, first of all, what are you looking at? What is this diagram showing here?
Is it showing the anterior?
Surface of
Yeah,
wrist or
anterior
triangle?
triangle.
How would you explain? Can you tell me what this C is, labeled C?
See, I think it's common carotid artery.
Yes, okay. What is the course of it? How does it go? How does it arise in?
It arises from the, for the right common carotid artery, it arises from the brachiocapillary artery, which originates from the arch of aorta, first part, and then it goes up to the C4 level. At C4, it divides into external carotid and internal carotid.
Okay, so which one would that be? Is it external carotid or is it common carotid?
I think it's common carotid.
All right. Okay.
Sorry, external carotid.
Yeah. Okay. So this external carotid artery, how does it terminate?
It terminates at the temporal region by dividing into superficial temporal and maxillary arteries.
Very good. What are the other branches of external carotid artery?
Other branches include ascending pharyngeal, superior thyroid, lingual artery, facial artery, occipital artery,
Yes.
posterior auricular artery.
Yes, maxillary, have you told? Okay, good. Can you please tell me what is this 22 that you're looking at?
22. It is common.
You have to think from here. It's starting.
This
This is 23 and this is going above. Now tell me, please.
It's common carotid.
Yes. Okay. Can you please tell me what is carotid body and where exactly is it located?
A common carotid body. It
carotid
lies.
body. Yes.
It lies just right posterior at the posterior wall, at the bifurcation of the common carotid artery.
Yes, and it contains what?
It contains chemoreceptors. It's sensitive to pH of the blood.
What is carotid sinus, please?
Carotid sinus lies just above, superior to the bifurcation, and it contains baroreceptors, which is sensitive to blood pressure of the body.
Okay. Right. Can you identify this nerve? It's in number 1 and it's in yellow.
I think it's friend enough. Sorry. Can I skip this question?
Okay.
Come back later.
You'll say I'll come back to this question later.
Yeah.
Okay.
Can I come back to this question later?
If you could, if you could tell me, I have basically asked you all the questions like, okay, tell me about the great auricular nerve. What is the root value and what is the area of supply?
Greater auricular nerve?
Yes, please.
I think it is root value is C1, C1, 2, 3.
C23.
C23, yeah.
Yes.
And it supplies area around the ear.
Okay.
Yeah. I'm a bit confused.
Area over the angle of the mandible is skin over the parotid gland and skin over the lower half of the auricle.
Yes. Yes, around that area.
It's if I'm not wrong, it's this 12 over here. Okay, good.
Okay.
Good, thanks. I basically asked or evaluated you everything what the heading like. And here is your question. Right. So if you have read and understood, considering it critical care scenario, kindly tell me how would you manage this patient now?
I would like to manage the patient as per the CRIS protocol.
Good.
First, I would like to look after the airway, breathing, and circulation.
Okay.
I would like to speaking. I will consider that airway is patent. If patient is not speaking, then I'll look for the nasal cavity and oral cavity and feel for the breath. Following which, if necessary, I'll proceed further. And I look for breathing for his chest movements, bilateral chest movements, whether expanding equally or not. Likewise, for circulation, I look for his pulses, and also I will be taking the blood samples for the necessary investigations. Proceeding further from airway breathing, I would like to stop all the fluids whichever has been going on.
Very good.
Then I would like to keep the patient on a high flow oxygen.
Okay.
In the meanwhile, I'll be calling for the help. Following
Yes.
which, I'll start the patient. I'll be starting the patient on diuretics,
Yes.
probably IV furosemide.
Very good.
Then, as patient is hypertensive and tachycardic, and I would
Yes.
like to liaise with the ITO register, and I'll following which I'll request for an chest X-ray, ABG, and electrolytes along
Very
with
good.
ECG.
Very good.
Then I'll proceed further with medical management of hypertension as well as for the desaturation. So I
Very
would like
good.
to place the patient on ventilation for oxygen support, probably CPAP,
Okay.
or then medical
What
management.
Yes. What
for
is what are the advantages of having patient on CPAP?
In case of patient on CPAP, it is mainly useful for cardiogenic pulmonary edema in case of secondary to
Yes.
hypertension.
Yes. How does it help the patient? Does it reduces the preload or is it reduces the afterload? How does it help or how does it contribute to the lowering the patient symptoms? So you have to tell me in that sense.
Continuous positive airway pressure, like to keep the airway patent.
Yes.
So there is enough amount of oxygenation being taking place at the level of alveoli, which further decreases the preload as well as the afterload.
Very
But
good.
most likely
Okay.
it's a preload reduction.
Yes, mostly
Okay.
it's preload.
So
Okay, then which
then
inotropic
for
sport would you consider for this patient?
probably dobutamine,
Why?
if it's secondary because of this secondary to cardiogenic shock,
Okay.
or
What are the
dopamine.
symptoms that that make you think that patient might be
You think
undergoing cardiogenic shock?
Patient will be having facial puffiness. Likewise, he'll be confused, and also patient will be gasping for breath, or there will be desaturation, and there will be crepitus on bilateral examination of bilateral lung examination,
And
there is
neck vein?
puffiness of the face with congested neck veins. Congested neck
Congestion of neck
veins.
veins. Very good. This is what
Yes.
I wanted to hear.
And pedal
Okay.
edema.
Can you please consider or comment on the resuscitation fluid which patient has been taking or has been given?
As per given chart, it is
Yes.
shown that crystalloids plus colloids were given approximately at rate of 7 liters,
Very good.
in
Yes.
which normal saline was 4 liters.
So what does it tell you? Has patient been given more fluid?
The patient has been given definitely has been given overload of fluids has been given. Excess
Yes.
fluids have been given.
Yes.
Following which the patient developed pulmonary edema that had lead to desaturation and resulting in a tachycardic and hypertension.
Okay, very good. Can you please tell me what are all the possible alternatives that you can offer this patient to manage the fluid overload?
To manage the fluid overload, firstly, I would like to keep the patient on Lasix. That will reduce.
Propped up, and then yes.
Yes, first propped up position.
Yes. Then,
following which I'll give oxygen support.
Yes.
Then I'll keep the patient on Lasix. That will reduce most of the fluid.
Yes.
Following which I would like to keep the patient on morphine, IV morphine.
Yes.
Then I would like to give bronchodilators. With that.
Okay,
and
what is the role of
glycerol trinitrates
what
for
is the
reducing the
role of rotating tourniquets in patients with fluid overload? How does it work? Or does not work at all?
sorry, ma'am, I'm not exactly aware of that.
Okay. How would you or what would you keep on measuring and how frequently to make sure patient is adequately hydrated now, or you are taking care of fluid overload?
Ma'am, I would like to keep the patient on continuous monitoring for
Yes.
his vitals first, then following which the input out of the amount of fluids had been
Yes.
given and the
Yes.
urine output.
Yes. How frequently?
And yeah, and also I would like to keep patient on insert on CV line for a continuous monitoring of the central venous line to look for
Okay.
the pressure changes.
Yes. How frequently would you be monitoring vitals and output?
It's continuous monitoring of vitals with a hourly charting of half
Hourly.
hour to hourly
Okay.
charting of the.
What should be the minimum urinary output that you expect?
Ma'am, as per the adults, the minimal output should be at least 0.5 ml per kg per hour.
What should be the urinary output for it to be labeled as oliguric?
It should be less than 30 ml per hour.
Okay, and any other condition? What are the conditions which contribute or lead to oliguria?
In case of okay, post-operatively, the patient can be in oliguria secondary to the post-operative surgical response.
Very good.
Or
Okay.
in case of any anesthetic agents that leads to release of vasopressin from posterior pituitary,
Yes.
resulting in the fluid and water retention.
Yes.
And also in case of congestive heart failure with low renal perfusion.
Very good. Okay. What happens when there is low urine output and you give fluid overload? What is the mechanism?
So
yes.
urine output, there is a shutdown of the renal mechanism, following
Yes.
which if increased fluids had been given, that results into the edema in all the interstitial spaces, likely pulmonary edema,
Okay.
cerebral edema.
Yes. And
Yes.
that leads to how it leads to renal injury. Ischemic.
That leads to again. Yes, ma'am. Again, it leads to a prerenal failure mainly.
Okay, good. Okay, can you please tell me what is the normal daily requirement of sodium and potassium for an adult?
Sodium is 1 to 2 milliequivalents per kg. Potassium is 0.5 to 1 milliequivalents per kg.
Where would you be managing this patient and who would you involve in the management?
Definitely, I would like to manage the patient in a ICU. So I would like to involve the
high dependency unit.
High dependency unit, HDU, and I would like to liaise with the registrar and the staff nurse and inform the chief officer regarding the condition of the patient.
All right, good. Okay, what are the differences in high dependency unit and ITU, intensive?
Oh, sorry, ma'am, I'm not exactly aware of this.
Okay, these are the small questions, you have to know the answer. All right.
Sure, ma'am, I'll go through.
How this fluid overload affects cardiac system? Can you explain?
Sorry, ma'am?
How this fluid overload
Can you please repeat?
how this fluid overload would affect the cardiac system?
Yes, ma'am. Fluid overload results in a cardiomegaly, following which there will be
not right away. First, what would happen? Fluid overload is going to affect low cardiac output. Then that will result into decreased renal perfusion, decreased output. And then what will happen? This, okay, you said left ventricular end diastolic volume will increase.
Yes.
Then
left ventricular end diastolic volume will increase. That will result in a
how would it affect actin and myosin? of the cardiac
Sorry, ma'am.
muscles. They will no longer overlap each other. Okay. Whenever in normal integration, they integrate, but in overload, they will not overlap each other. So what will happen? This will even worsen the condition, and
aggravate the failure.
Yes, it will decrease the stroke volume and cardiac output even more. So that's the mechanism. Very good. Right, good. Can you please help me read the X-ray?
Yes, ma'am. In the given patient X-ray, there is opacity seen in the lung parenchyma and bilateral lung parenchyma. Likewise, there is a definitely cardiomegaly, and also there is a obliteration of the cardiophrenic angle.
Yes.
With ECG's lead has been connected.
Yes,
and there are.
How about the lung field?
Yes, ma'am. Interstitial edema has been noted.
Yes.
Along with curly B lines.
Yes, good. Thank you.
And yeah, and a typical pattern of bat wing appearance, alveolar edema.
Good. Thanks. Thank you. And here is your question. Right, so if you have read and understood, considering the clinical examination station, kindly begin.
Yes, ma'am. So I'll enter the station. I'll wash my hands. Hi, I'm Dr. Snehal, one of some candidates. May I know your name and age, please?
Yes, 32, Samantha.
It's nice to meet you, Samantha. So today I've been asked to examine the gland in your neck, which involves looking, feeling, and touching your gland, also doing certain special tests after exposing your neck. Is it all right with you?
Yes.
Thank you so much. If you need any chaperone, my examiner would be my chaperone.
No,
your chaperone. Thank you.
You don't need a chaperone for this one. Continue, please.
Okay. Okay. Yes. Thank you so much. So now I'm going to start by taking a close look at your neck. Can you please loosen the collar of your shirt?
Yes.
Okay. So I'm going to take a close look. I will. Can you please point me where you find this lump?
Below my jaw. So okay, what are the 6 S that you look for on inspection?
Yes. So I will look for size, site, shape, surface, skin over the swelling, and any scar marks.
Very good. Anything else?
Yes, I would also look for any abnormal pulsations, any surrounding other swellings apart from this swelling.
Yes.
And yes, ma'am.
And you look at the contralateral side as well, because this is on right side, so you look at the contralateral side as well.
Normal
okay,
side.
Yes.
Yes. So thank you so much. Can you please show me your teeth? All right. Thank you so much. I will check for marginal mandibular nerve. Then can you please stick out your tongue after opening your mouth? All right. I'll check for hypoglossal nerve. Can you please put your tongue against your cheek? I'm going to push it from outside. So I've checked for hypoglossal. All right. So I'm going to need a torch. Can you please open your mouth and stick your tongue up? So I'm going to look for the opening of the submandibular gland on both the sides, and also any swelling from inside the floor of the mouth on both the sides. All right, Samantha. So thank you so much. Now I need to feel your gland. Is it okay with you if I examine you from the back?
Yes.
Yes, thank you. So I'll go behind the back and I'll rub my hands to warm them up, and then I'll check for the temperature. Okay.
Yes.
Do you have any pain at the moment? Please let me know if you have any pain or discomfort. I'll stop.
Okay.
Uh,
Okay.
Thank you so much. So I'll come to the side of the patient from back, and then I'll check for the tenderness. After that, I'm going to check for the bimanually. I'm going to check for the, again, the site, size, the surface, edges, or consistency of the swelling, and the whether the swelling can be rolled up, whether it is freely mobile, and the skin pinch test. Also,
Very
I'm
good.
going to do a check for the opposite submandibular gland. After that, I'm going to feel for more glands in your neck. Is it all right?
Yes.
So
Before
I'll
that,
check
make
for
sure
the,
if there is Wharton stuck by
yes, okay, ma'am.
manually. Yeah.
Okay, all right. So I'll come in front, and yes, Samantha, for now I need to, I'm going to put a clean glove in my hands, and I need to check from inside your mouth. Is it okay with you?
Yes.
Yes, thank you so much. So I'll check for the bimanual examination of the gland, the deep lobe palpation, and also I will palpate along the floor of the mouth to see for the Warthin's duct, any stone or any discharge is present or not. Also,
Yes.
I would like to change my glove and check the opposite duct in the same way.
Yes.
After that, take a cotton sweep and okay. Can you please do this on your left arm? Okay, so I'm going to put this on your tongue to check the sensations of your tongue. Please close your eyes and please tell me when you feel same. So I will test on both the sides. All right, Samantha. So now I need to go back to your back again, and I need to check the few glands in your neck. Is it all right?
Yes.
So I'll go back and I'll check for submental, submandibular, upper, middle, lower, jugulodigastric, supraclavicular, and preauricular, postauricular, and occipital group of lymph nodes. So thank you so much, Samantha. I have finished my examination. I'll go back to my consultant and come back to you. Do you need any help dressing up? Is there anything else I can do for you? Then
No,
I'll
that's all right. Thank you.
wash my
Yes.
hands again.
Yeah.
Yes.
Now you can present your case.
So I have
2 seconds
examined.
are left. Yes.
I have examined a lady with 32 years old lady complaints of right-sided neck swelling below her jaw.
Yes.
On inspection, the size of the swelling is around 2 to 3 centimeters. The skin over the swelling is normal. The edges are smooth and well defined. The
Yes.
surface is smooth. No scar marks. There is
Yes.
no erythema or any skin changes surrounding the swelling. There are no other swellings or pulsations visible in the neck. On inspection
How
from
big was the swelling?
it was about 2 to 3 centimeters in
Okay, good.
size, oval in shape.
Yes.
Yes, thank you so.
Oh,
From inside
yes.
opening of the Wharton's duct, there is no abnormal discharge, redness, or swelling seen inside from inside of the mouth. On palpation, temperature is normal. There is no tenderness. The
Good.
consistency of swelling is firm. It is oval in shape, smooth surfaced, well-defined regular margins, and the skin pinch test is negative. It is skin. The roll-up test is also negative. And on palpation from inside, the deep lobe is not palpable. There are no stones or any abnormality palpable along the course of Wharton's
Very
duct.
good. So what are your differential diagnosis for this patient?
So it can be, ma'am, either an swelling which is benign or malignant
First,
tumor.
benign, it could be silolithiasis, it could be stone, it could be infection. And then at the end, you can say it could be neoplasm. Okay, how would you investigate this patient? What would be your next step?
Yes, so I would like to go ahead with the thorough systemic examination, and
Yes.
also I would like to examine the other glands, parotid and sublingual salivary glands.
Yes.
After that, I would like to go ahead with certain blood tests, such as complete blood count, electrolytes and urea creatinine, and markers of inflammation such as CRP and ESR.
Yes.
After that, I will go for imaging studies such as ultrasound or CT or MRI, depending upon the finding.
Silogram and silogram. Okay.
Yes.
And FNAC at the end. Okay. What are the treatment options that you can offer this patient?
Yes. So if the patient has a stone, then it would be we would go either a siloendogram or the duct excision, or a complete or total submandibular gland excision if the stone lies deep in the gland.
If it is infection?
Then incision and drainage.
Are you sure?
No, ma'am.
No.
I'm not sure.
It's conservative management. You give analgesia and oral antibiotics and food hydration.
Okay.
Then you don't, it's not abscess, it's like infection in the duct. So
Okay.
with, conservative management, it gets better. Very good, very good. Okay. Yeah, good. That was very thorough. Very good. Really impressive. Thank you. Here is your question. Right. So if you have read and understood, considering it's surgical and not surgical pathology station, kindly tell me what are your differential diagnosis for this patient?
This patient, my differential diagnosis, lymphoma or pseudoaneurysm or inguinal hernia, or indirect inguinal hernia, and testicular teratoma and undescended testis.
Okay, how would you confirm your diagnosis?
To confirm my diagnosis, I should need clinical examination and
Yes.
investigation. Investigation by ultrasonography, and also scan, and I do some tumor marker like beta ICG, lactase dehydrogenase, and alpha fetoprotein.
Okay. For this patient, since this patient has only one single testis palpable, so why you thought of lymphoma as your first diagnosis?
Because there is a swelling in the inguinal region, inguinal mass. So I first say that lymphoma maybe.
Okay.
It also be
Yes.
undescended testis or testicular teratoma also. Need to
Alright.
proper investigation.
Yes. Okay. In what you said you'll go for ultrasound. If you'll do ultrasound, what would it show?
To ultrasound, I want to see that one side of testis is palpable and another side testis is not palpable. So I want to ensure how a testis is present or not, or it is
Okay.
undescended or it is on
Okay.
ectopic side.
Okay. Can you please tell me what is the condition which is called, all right, okay, you said you'll confirm it's absent or present. All right, if it is right, if it's testicular carcinoma, so what are the different types of testicular tumors that you know of?
Testicular tumor are germ cell and non-germ cell. Germ cell seminomatous and non-seminomatous. Seminoma seminomatous tumor are seminoma and spermatocytic seminoma, and non-seminomatous are choriocarcinoma, exact tumor, and also teratoma. And sex cord
Okay.
tumor are also Leydig cell tumor.
Considering the age of this patient, what is the most likely testicular carcinoma that can occur in this age group?
Patient age is 35 years old. I consider it is mostly seminoma because below the
Why?
30, patient below the 30 is teratoma, most
Ye-
common, and above the 30 is seminoma.
Above 30, it's teratoma. So what is teratoma, please?
Also, teratoma is a testicular tumor which involves three germ layer.
All the three germ layers. Okay. Can
All the
you
three.
please tell me what are the causes of testicular carcinoma?
Testicular carcinoma risk factors are including family history and premature or low birth weight baby, undistant testes, and also for
Okay, can you please define the term cryptorchidism?
Cryptorchidism means a complete or partial failure of descent intra-abdominal testis into the scrotum.
Yes, associated with
Associated with increased risk of cancer and
testicular dysfunction. That is important. Okay, what are the
a
causes?
testicular dysfunction.
Yes, what are the causes of this condition?
Due to family history,
Very good.
sorry, I missed family history and
Low birth
premature or
weight.
low birth weight
Yes,
baby,
yes,
raised inter-abdominal pressure or Down syndrome.
yes. If you don't manage the condition or don't treat it adequately, what are the complications that can result?
There is increase the risk of testicular cancer, infertility, increase the risk of torsion testis,
Okay.
and testicular dysfunction.
Can you please tell me if you did all the investigations and you sent the report and the biopsy report comes back and it is declared that this is seminoma. So what are the treatment options that you can offer to the patient?
Before go to treatment, we need to staging the tumor. So I go for CT scan of pelvic and abdomen, and then treatment according to the staging. If
Yes.
it is a carcinoma, so we need orchidectomy plus chemotherapy. Also, if any lymph node present, then we go retroperitoneal lymph node resection.
Okay, can you please tell me what are the tumor markers which can help you with diagnosis for each teratoma
tumor
and seminoma? Each different one. Yes.
For teratoma is first, then lactase dehydrogenase and alpha feoprotein. And for seminoma, we go for beta human chronic gonadotrophic hormone, also alpha feoprotein.
Okay. Can you please tell me what are the differences or what is the most common location of undescended testes?
Most common location is inguinal ring.
Inguinal canal or external
Canal. Canal.
All right. Can you please tell me how would you differentiate between ectopic testes and undescended testes?
Undescended testis is present in its pathway, the abdomen to scrotum through inguinal ring, but in ectopic testis is present outside the pathway, maybe on the femoral area or the perineal area or superficial of the inguinal ring canal.
And undescended
also,
testis is usually undeveloped, whereas ectopic testis is fully developed. And please tell me two more differences.
And
Two more.
And
please.
undescended testis maybe the cord is short, but in ectopic tendency, the cord is maybe normal.
Okay, and is
And
there any treatment difference?
undescended
yes.
testis, yes, we can correct it in position, or it is not necessary to excision. But in ectopic pregnancy, we should remove that testis, I think.
Okay, here is little wrong. You do surgery in
Yes.
both, but in undescended testes, you have to give hormonal therapy as well,
Yes.
because testis is underdeveloped. It's not fully developed. So you'll remove it in both cases. It will become cancer if you will not remove, but you have to give additional hormonal therapy for that one. Right,
Okay,
and
ma'am.
the complications are more or less the same. Yeah, I didn't ask you about. Okay, I kind of asked you. You told me about the list of the differentiations of WHOs. Okay, I think I've covered the whole. Right. Age, you got a little confused. If it is over 30, 30 plus, 35 plus, it's teratoma.
Yes, ma'am.
If it is under 30, it's
Okay.
seminoma. That's all. Thank you.
Okay, thank you, ma'am. I missed.
And Patel, and here is your question. Right. So if you have read and understood, considering your communication skills station, kindly begin.
Hello, I'm Dr. Muhammad Al doctor. I'm working
Hello.
with Derma at hospital. I am calling out to speak to Mr. X and to ask him an advice about a patient who has right hemocolostomy with cortical tumor, and he's now oliguric. May I confirm who I'm speaking to?
Yes, I'm Mr. Mann. So
Okay,
who's the
thank you.
consultant of this case?
He is Mr. John.
Okay. Can you please summarize your case?
Okay. This 90-year-old woman who has post-1, he has underwent elective hemocolostomy for cortical tumor, and also she has liver biopsy with suspected. Now the patient is oliguric with urine output about 10 to 20 milli per hour, and also she is cardiac and hypertensive. Blood pressure is 90 over 60, and he has temperature is 35.5. The patient also has received 2 units of blood, and also all of her investigations, his ECG is normal and her chest X-ray is clear and abdomen is soft. But there is increased borderline of high creatinine.
Okay. So what do you think the cause is?
I think she might have dehydration because he is only 1,100 milli of fluid built up, and also there was bleeding. The operative received 2 units of blood.
Okay. So what will you do now?
Okay, my plan of action, I will manage her according to this protocol, including AFCD approach, and also I will focus on fluid patients. I will give her 1,000 ml of fluid over 1 hour, and I will monitor her response accordingly. After that, I will update you.
Okay. And do you want to involve anyone else in the patient's care? Do you want to transfer this patient anywhere?
Yeah, if patient is not responsive to fluid resuscitation, I will consider the transfer her to HDO unit for the inserting central venous pressure line, and also if there is no response to fluid, I will consider her blood transfusion.
Okay. So when was the blood tests done for him last?
But about 2 days ago.
Okay. So do you think that the patient is bleeding?
I think she might have bleeding, but now I will check her vital signs, and also I will do serial abdominal examination. If there's any sign of bleeding, then I will update.
Okay. Do you think she is having anastomotic leak?
By now, he is not toxic, and her abdomen is black, and there is no sign of peritonitis. But I will keep doing serial abdominal examination. I will order some abdominal ultrasound. If there is any sign of peritonitis, I will call you.
Okay. And do you want me to come back?
If there is no response to her fluid situation as any sign of bleeding or peritonitis, then I will update you.
Okay. And what fluid would you give? How much amount exactly for fluid challenge?
Okay, firstly, I will give her 250 to 500 milli over 30 minutes. Then I will keep monitoring her vital signs. If there is no response, then I will consider her blood transfusion.
Okay. And have you checked the patient's catheter for any blocking?
Yes, I have checked the catheter and there is no problem.
Okay. Okay. Thank you so much. Thank you. Please keep me updated.
So,
Yeah.
okay, can we summarize what we have been through?
Yes. Yes.
Okay. 90 years old female who have underwent right hemicolectomy for fetal tumor, and he is now reviewing, is hypotensive and tachycardic, and also her temperature is normal, and her unit output about 10 to 20 milli per hour. And also there is a borderline high creatinine level, but her abdomen is full, and there is no sign of peritonitis or abdominal bleeding. I will manage her corticosteroid in the approach. I will focus on fluid patient. If no response, I will consider transfer the patient to ICU. Then I will update you accordingly.
Okay. Okay, doctor. Thank
So
you.
if you
you
think
very much.
high dependency unit is full, then who would you speak to?
I will speak to bed manager
Okay.
regarding patient or transfer or early discharge patient.
What do you think might be the cause of shock in this patient?
Most likely has dehydration, so it might be hypovolemic shock, or it could lead you to bleeding, so it could be hemorrhagic shock.
Very good, because it's a post-op first post-op patient. Right, you still have 1 minute. That's why I'm asking this. Did you tell if the patient requires operation now?
Sorry?
Did you answer if the patient requires to be operated upon now?
You didn't ask me about that.
Yes.
Yes, I think she did.
Okay.
Did he tell you about the fluid challenge? How much he would give?
Yes. Yes, ma'am. He told me 250 to 500 ml in the next 15 to 30 minutes.
Okay. All right.
Yes,
Because
ma'am.
1 minute. All right. Okay, we'll end. Because 1 minute was left, so I was now 30 seconds. All right. You can kindly give feedback. Okay.